That's what
To tell us about this, we have Gururaj Purani. Thank you.
Good afternoon, all. Thanks for giving me the opportunity. So that's the topic. How fast? Fast track take care. How fast is it? So fast track means different meaning to different people. If you look at this ad, you would think that patient will run, and that's marketing strategy after TKR. I WhatsApped my UK colleague and who messaged me back, and he thought that fast track means bringing forward the patients in the waiting list, in NHS waiting lists, those who have problems like valgus, OA and things like that. My US colleague came here and he thought that they won't do any fast tracking, but they do TKRs. What about the patients? Well, they can think anything from here to there, and it's up to us to counsel them. So let's look at the surgeon's perspective now. In 2010, average length of stay in Europe was about 6 to 10 days following knee replacement, which has been brought down to almost outpatient joint replacements now, thanks to this fast tracking. This is considered to be one of the most significant advances in surgery in 21st century, along with the damage control surgery and minimal invasive surgery. But before we go there, look at the bigger picture in the scheme of things. So if you want a successful knee replacement and a happy patient, obviously you have to fulfill all those above 4 criteria as well. So select the correct patient, set the appropriate expectations, avoid the complications, know your instrumentation and skills, and finally comes what we call as fast track, but in fact it is multimodal perioperative pathway. There are various names for this. I would prefer enhanced recovery after surgery. That's the correct term for fast tracking. What is the definition? It's a multimodal perioperative care pathway designed to achieve early recovery for patients undergoing major surgery. Now, there is a society in Europe based in Sweden which is called Enhanced Recovery After Surgery Society, and they have issued guidelines to various different subspecialties as well, including hepatocellular, etc. Where does it start? Well, if you look at the history, it was first published in 1994 following a coronary bypass patient, and that was the beginning of this. But the most important person who is credited with this is Professor Henrik Kellet, who popularized it. And he noticed following a colorectal surgery, using the principles of fast track, that there was decreased morbidity, patients were able to go home early. And so he published a paper in British Journal of Anesthesia in 1987. I'm just going to briefly talk about the principles that are mentioned in this article. As you all know, any surgery or any damage, any trauma in the body results in eliciting of a surgical stress response that is mediated by the trauma-induced endocrine metabolic pathways and also several biological cascades. That is supposed to help give survival benefit to the patient, but if it happens in excess, then it can cause bodily damage. And Professor Kellet hypothesized that if you can stop this or reduce this effect of this stress response, then patients will have less post-operative morbidity and can go home early. And so he initially thought one is the basic principles are minimally invasive surgery, so reduce the stress and then block the response of the stress by blocking the afferent nerves by giving local infiltration anesthesia, and also post-operative morbidity by reducing episodes of pain, vomiting, etc. These are the recommendations given by ERAS Society. I'll just quickly go through them. So there are pre-operative, intraoperative and post-operative. Pre-operatively, no smoking for 4 weeks. Anemia needs to be corrected. The age-old do not eat and drink after midnight doesn't apply anymore. Clear fluids can be given up to 2 hours. But this is difficult aspect because some of the anesthetists may not be very keen for this. Intraoperatively, GA and spinal both do well, but nowadays, recently, spinal anesthesia is being favored. Epidural anesthesia is not recommended anymore because it causes hypotension, urinary retention, etc., delaying discharge. Tranexamic acid is one of the most important drug in this, where it reduces bleeding, it reduces the need for tourniquet use. Local infiltration anesthesia is recommended, mainly for the knee but not for the hips. Normothermia has to be maintained so that there won't be any catabolism. And as I said, tourniquet is not recommended anymore. And if you don't want to get rid of your routine thought process that I should not, not use tourniquet, then think about THR, where you won't be using any tourniquets and you still will be cementing if you are a cemented surgeon. So similarly in the knee also you can do the same. And surgical approach doesn't matter. There is no specific superiority of mid-vastus approach for this. Perioperatively, patients are mobilized on day 0, day of surgery, because there has been evidence which has been published by Professor Michael Mond, who felt that the discharge will be quicker if they walk on the same day. Even if there are few steps, they felt that in discharge, the patients will be able to go home earlier. Standard DVT prophylaxis, IV fluids are discouraged, early oral take is encouraged. Catheters are not indicated unless patients have a threshold of 800 ml in their bladder, but even if you catheterize it, take it off immediately. Wound drains are not used. But the most important take, if you want to take from this talk, would be the functional discharge criteria. I think we should not forget in the rush to send the patients home what is really important. And this is the important part of it. Patients should be able to walk, they should be able to get in and out of bed, they should be able to sit and get up of the chair or toilet with sufficient pain relief. And I think that's where the criteria is. There are various protocols. This is one from UK protocol, which is, I use it, where there is preoperatively, we also use steroids. Intraoperatively, we use triple closure. There is another protocol from Europe, one more from US. So what is the evidence? If you look at the evidence, this is level 2 publication in JVJS in 2021, which is a systematic review of prospectively collected data of about 7,000 plus patients, of which 2,000 plus were ERS, and they significantly reduced the hospital stay without any causing any readmissions or comorbidities. Professor Carrot also published this, which is fast track, daycare. That was the time people started thinking about daycare. I'll briefly look into Indian scenario. So how much of daycare you can do in India? I think there's not much, because these are the criteria. Patients should be less than 70. They should be ASA grade 2, not more than that. And many of the patients are undiagnosed diabetes in India, which are grade 3, ASA grade 3, so they won't fit. Weak quadriceps, because they've been having knee pain for a long time. So the weakness of quadriceps itself delays rehab. Inadequate pain control because of prolonged pain. Lack of awareness and low level of confidence in daycare also plays a part. Cost of follow-up. So even if you say daycare in US, what they do is they have got a separate facility next to the surgery facility, ambulatory care facility, where they go and stay there for 2 days or so. So it's not really a daycare in that sense, because that also has got nursing care, etc. Obviously, anesthetists are the biggest worry for us, because they won't let us, they want even normal TKR to be sent to ICU after surgery. So it's difficult for us. It's teamwork really. So these are the discharge criteria, exclusion. Yeah, quickly, two slides. Exclusion criteria, quite a few of them are there. So you'll have to really choose your patients like these ones to go for a day case TKR, which are not many. So finally, coming to my question, fast track TKR, how fast is it? Well, the discharge at the moment is 0 to 3 days. Many of my patients go home on second day itself, post-operatively, including bilateral total knee replacements. If you can not use tourniquet, use tranexamic acid, you should be able to send them on second post-operative itself. What about day case? Well, daycare TKR, condition supply, select correct patients, maybe you should be able to go home, but you should have a post-op backup. Thank you.
Thank you, Dr. Bhavina. Interesting concepts. We will need to see them in the context of Indian scenario, isn't it? Yeah. We'll have some questions if the time permits.